Hello, my name is Amin Al-Ahmad from Austin, Texas, and it's my pleasure to present to you ablating outside the PVs with the Cryoballoon Catheter techniques and expected results. First of all, before I'd like to simply thank the organizers of Latin HRS and tell you that I wish that we could do this all together, and perhaps next year we'll meet as colleagues and friends in Latin America. These are my relevant disclosures for this talk. In thinking about the cryoballoon, you have to realize that the cryoballoon has advanced since its inception. The original cryoballoon, which had a diameter of 28 millimeters, had a fairly long nose to it, and the freezing was really limited to 4 parts. The newer cryoballoon, the nose is a little bit longer, but the freezing is really all around the front of the balloon. So it's really able to provide a deeper and more robust therapy. Just to show you an example, the surface area in the newer cryoballoon is much more uniform and much more cold on the front surface of the balloon. And this allows people to potentially use this balloon in other techniques. Now, it's also worth noting that because of the nose of the balloon and how it's designed, the cryoballoon is really designed for pulmonary veins. It's really not designed to put somewhere else, but obviously there's a lot of talented people who've figured out ways to do this. This is just an example here of showing you the newer cryoballoon on the bottom, how cold it can get as compared to the newer one, the older one. And again, allowing us to potentially use this cryoballoon in areas that we wouldn't normally be able to have success with. And again, understanding the limitations of the design. So the real question, I guess, is why target areas outside the PVs? It was designed for the pulmonary veins, but I think this is a question that hopefully has been answered over the years. We consider obviously the posterior wall to be part of pulmonary vein tissue. In utero, as the heart is developed, this tissue really grows into the front part of the heart, and so oftentimes fairly arrhythmogenic. And there's been a fair amount of data that suggests that completing the posterior area, if you do it well, can add to your success. Here's just some examples. You can see in these CT scans how really there's hard to distinguish the posterior wall of the atrium with where the pulmonary vein antrum ends. The tissue in the pulmonary vein posterior wall and the pulmonary vein is essentially all venous component and similar. And again, there's a fair amount of data at this point that suggests benefit to doing this. In fact, posterior isolation may be considered for initial or repeat ablation for persistent or long-standing persistent. Another area of concern is so-called non-pulmonary vein triggers. And these are areas where after you've ablated the pulmonary veins, for example, in this example here, you can see the pulmonary veins and the posterior wall are red. After these areas have been ablated successfully, there remains atrial fibrillation, and it can come from other areas of the heart. Now you can see, at least this is from a paper showing our group's experience. When patients come for a second procedure, you might see some PV reconnection in about a third of patients. But by the time they come to their third or even fourth procedure, it's really the non-pulmonary vein triggers that are the problem. And even in the second procedure, non-pulmonary vein triggers are a bigger problem than pulmonary vein triggers, if at least you've done a reasonable job with the pulmonary veins at that point. Here's another group that looked at this. This is the University of Pennsylvania, my good friend, Dr. Santangeli, who looked at pulmonary vein triggers, and they used incremental doses of isopaterenol in order to find them. But importantly, you can see some of the distribution of areas in this bottom graph here. You can see paroxysmal, persistent, and longstanding persistent. That progressively, areas like the coronary sinus, the atrial appendage, all of these areas increase as the AFib becomes more progressive. This is from our experience. We tend to find a lot of these triggers in the coronary sinus, left atrial appendage, septum, and SVC. Now, with cryoballoon, you really can't target the coronary sinus, not easily at least. Left atrial appendage may be targeted, and I'll show you examples of this. The septum could be potentially targeted, but you have to worry a little bit. And the crista and the SVC, certainly the SVC can be targeted. The atrial appendage is an under-recognized site of AFib ablation, and this has been borne out now by multiple groups as well as by a randomized study called the BELIEF trial that showed that it's important in patients with persistent or long-standing persistent atrial fibrillation. And here you go. This is just examples of multiple studies from multiple operators and groups that have shown the same thing as far as the left atrial appendage goes. Well, so you can do a lot of different things with cryoballoon. So here's an example. You can target the left atrial appendage. You can target the superior vena cava. You can target the left atrial roof and posterior wall, and you can target the right atrial appendage. Now, all of these areas, you have to bear in mind that there are certain risks associated and certain concerns, but these are all areas that you can target. Turns out that if you just use cryoballoon, most of the posterior wall, or much of the posterior wall, at least in a small atrium, has been ablated. You can do a pretty good job almost completing the ablation. So how do you go about this? So there's a lot of maneuvers that you might need to learn, but essentially because the cryoballoon has a nose on it, what you want to do is anchor the balloon by placing either a wire or the circular mapping catheter that comes with it, the Achieve catheter, into the pulmonary vein and pulling back and essentially holding it up and freezing it. In doing that, you can make these types of maneuvers. This is a slide from Arash Ariana, and you can sort of see how simply by doing that and pushing it posteriorly, you can isolate the pulmonary vein. You need to have an anchor in the pulmonary vein, and you need to have the sheath helping as well to steer this device. Here's more examples of trying to get on the right side. So you can anchor the wire or the Achieve catheter in the left sided veins, but you'll also need to anchor it in the right sided veins. And in doing that, you can back out the balloon, push it towards the posterior wall, and ablate that area pretty effectively for the most part. Here's just a video recording that kind of shows you this. So you can see here, again, multiple areas. You're simply just pulling back, adding some torque, and freezing. Now, of course, in the posterior wall, because this is a fairly powerful balloon, you need to consider temperature in the posterior wall, in the esophagus. So we typically will monitor the esophagus, and if temperatures reach about 25 degrees, we'll stop our freeze at that point. You can use intracardiac echo, and this is a fairly elegant way of doing it. In fact, once you use intracardiac echo, you can associate it with CARTO as CARTO sound and simply identify where the regions that you've ablated. So this is just an example. You can see here by labeling the circumference of the balloon, you can see all of the areas that you've ablated, and when you go and you do a high density map, you can see that you've done some successful ablation in those areas. So when this has been looked at, this is a multi-center study. Now this is a retrospective study, but it's a multi-center retrospective study. It appears that at least in persistent patients with atrial fibrillation, if you were to target the posterior wall, you will achieve an increase in success. So posterior wall ablation tends to lead to success, at least in persistent patients with AFib. And so again, the strategy is placing the balloon in multiple locations and applying the energy, as you can see. And of course, using all the tools that you need to. Now, this is from this particular study. You can see a couple of things I think are worth mentioning. One is cryoablation time is only 16 minutes. Cryo applications 6.2, not a huge amount overall for the pulmonary veins. Now, when you add the posterior wall, another 16 applications, another 38 minutes. So all in all, this can be done fairly rapidly if you know what you're doing. And again, this is the success rate following the index procedure when you add posterior wall isolation. Fairly durable. If you go back and you map in some of these patients, you'll see that 88% of them had durable isolation of the posterior wall. In other words, it's red after they come back. There was some reconnections in patients who also tended to have reentrant tachycardias. And in these patients who had partial posterior wall reconnection, they tended to have atrial flutters. And so conclusion was you can achieve durable posterior wall and pulmonary vein isolation with cryoballoon application. I think this is fairly true with the new cryoballoon, really no doubt. Partial posterior reconnection frequently present with atrial flutters, and these can be ablated fairly easily, just touch-up ablation if necessary. Now, this particular study that I just showed you has prompted a randomized control study. Remember, the previous study was a retrospective study, but there is rationale now for a randomized study. So this is the study called the pivotal study, and it's about to be started. At least we're one of the participating sites that will look at this in order to see whether we can achieve success in randomized design. Now, what about the left atrial appendage? This can also be isolated. Remember, the balloon is 28 millimeters. You can cautiously push it up against the left atrial appendage. And if you do that and apply cryo freezing, you can see that occasionally you'll have dissociated left atrial appendage signals, meaning isolation. A couple of things you need to be cautious about. One is, as you push that, you're pushing a little bit closer to the phrenic nerve, and you need to be cautious about the left phrenic nerve in this particular case. And the other thing is, as you know, the circumflex artery runs right there on the mitral side of the left atrial appendage. And so there has been cases reported of spasm of the vein, of the artery. A couple other things to think about. Again, we mentioned the phrenic nerve. The phrenic nerve is also an important one in patients who are undergoing SVC isolation with cryoballoon, particularly because cryoballoon is fairly unforgiving. It's a very powerful tool. It works extremely well. So you need to be monitoring the phrenic nerve when you do this kind of thing. Coronary vasospasm has been reported, and so you can see here in the bottom panel where my arrow is a fairly long segment of vasospasm that typically will resolve with some time or some nitroglycerin, but this is one of the things that's important to be monitoring for as you're performing cryoballoon for the left atrial appendage. And another thing to consider, of course, is that once you've isolated the left atrial appendage, you really need to treat these patients like they have a mechanical valve. They cannot stop oral anticoagulant therapy at all. And optimally, if you can close the left atrial appendage, that would be ideal. This is just a survey of all the different types of maneuvers you can make to cover things like the roof, the posterior wall, left atrial appendage, the supravenous cable. All of these areas can be covered with cryoballoon. Again, it's not too difficult to do as long as you have a good anchoring. And once the balloon is frozen, it really won't move. So you can be fairly safe with that. Now, in terms of cryoballoon and left atrial appendage, there's been a few studies now. Actually, we can add to this another study from Europe that suggested that if you add left atrial appendage isolation to pulmonary vein, you improve outcomes in patients with persistent atrial fibrillation. This has been our experience as well in some of these more difficult patients. Whether you use RF or whether you use cryoballoon, you will improve outcomes. But again, a word of caution for these patients. So with this, I believe my time is about up. So I'd like to conclude. Cryoballoon is really designed for the pulmonary veins. However, manipulation of the balloon outside the pulmonary veins can lead to durable ablation, quite good ablation of the posterior wall, fairly easy to ablate successfully. Left atrial appendage, with some caveats in terms of safety, can be ablated successfully. Superior vena cava, again, worrying about the phrenic nerve and perhaps the sinus node, but again, can be ablated successfully. Right atrial appendage rarely is needed, but if it is, it can be ablated successfully with this. Now, there's recent data that suggests clinical benefit with posterior wall and left atrial appendage isolation with cryoballoon. We already have a lot of this data with RF. This is additive data, and it's important data. And again, there's unique risks such as left phrenic nerve damage, coronary spasm, and you need to consider these when you're doing these types of procedures in terms of weighing the benefits and the risks. So with that, again, I thank you all for your attention, and hopefully next year we'll meet together somewhere in Latin America without the plague of coronavirus over our heads. Thank you again very much for the opportunity to present to you.